Let's see if we can revise what is JVP, CVP, their clinical significance, their causes, pathophysiology of conditions affecting them, and basically a little bit of mnemonics. JVP is not jugular venous pressure, it is jugular venous pulse. So basically the pressure in the right atrium is reflected by the internal jugular vein. A little bit of anatomy. From the right atrium, we have the SVC and the IVC here. And then at the top, we have the brachiocephalic trunk from which we have the jugular and the subclavian coming out. The jugular then bifurcates into the external jugular vein and the internal jugular vein. The internal jugular vein being more straight in line with the right atrium is what we are measuring rather than the external jugular for the JVP. For measuring the JVP, we let the patient lie down at a 45-degree angle on the bed and we ask him to turn his head to the other side so that we have prominence of the sternocleidomastoid muscle. Just behind it, we have the jugular venous pulse. Note that contrary to that, we have anterior to the sternocleidomastoid, we'll have the carotid pulsations. There is a whole table given in any kind of book that you have for differences between the carotid and the jugular venous pulse, which is very important for your vagos. Main points include the position, like I told you, the fact that carotid pulsations can be palpated and JVP cannot, it can only be seen. The fact that carotid changes with respiration and jugular venous pressure, the pulse does not. And then we have abdominal pressure, hepatojugular reflux, which affects the JVP rather than the carotid, and a few other points. Now suppose in a clinical setting you have to examine the patient's JVP. The patient is lying on the bed at a propped up position of 45 degrees. You take two measuring rulers and you take one and place it vertically on the sternum of the patient, and the other one, what you do is you take the upper limit of the pulsations in the JVP and then you take it parallel to the ground and you take it all the way up to the second ruler, or the first ruler, and wherever it comes and falls is something you have to measure. So supposedly it is 2 centimeters. Now you take the 2 centimeters and you add 5 centimeters to it, because 5 centimeters is the distance between the right atrium, the top of the right atrium, all the way up to the surface of the skin where we have placed the ruler. So that we need to add to the superficial measurement. So it is 5 plus 2 for an example, and we have 7. So the normal JVP should be less than 7 centimeters of water. Now note that I said 7 centimeters of water and not mercury, because 1.36 centimeters of water is equal to 1 millimeter of mercury. This is an important pressure conversion that you should know. In a minute, we'll come to all the conditions causing an elevated or a decreased JVP. But first, I would like to discuss with you what central venous pressure is. So imagine instead of in a clinical setting just directly measuring superficially without any equipment, that was JVP. In CVP, what we do is we put a cardiac catheter. What we do is we take a catheter, there is a 3-way valve over here, and we take that catheter, pass it all the way up to the right atrium, just where the SVC enters the right atrium at the tip over here, and this is where we'll keep the catheter. Now when we're measuring this, now we don't need to add any extra 5 centimeters because we are actually putting in a length of the catheter that is going through that, and it is covering the distance that we earlier had to substitute. So normally the central venous pressure is from 8 to 12 centimeters of water, because we have already considered the amount of the length that we had to add before. Now it is included, so it is 8 to 12 centimeters of water. That is the central venous pressure. That is reflected here itself by putting the catheter in the right atrium tip. The clinical significance of central venous pressure is that if it is less than 8 centimeters of water, that means the patient is dehydrated and we need to increase the fluids that we are giving to the patient. If on the other hand the CVP is more than 12 centimeters of water, that means the patient is either overhydrated, that is fluid overload. So we need to take a little bit of a check on the fluid that we are giving to the patient. At the same time, we also check the IVC. That is, we will check that by doing a 2D echo. What do we check on the 2D echo? The IVC could either be collapsible or non-collapsible. If it is collapsing, that means if its diameter is less than, I think, 2, that means the patient is dehydrated. So you need to increase the fluid. Or if it is non-collapsible, that means the diameter is more than 2 of the IVC on 2D echo, then you will need to stop or restrict or decrease the fluids that are being given to the patient. That means the patient might be in fluid overload. That was just an extra point there. Now coming back to JVP. So JVP, this is a waveform that you need to know. It's very important. We have 3 upstrokes in the JVP, A, C and V. On the other hand, we have 2 downstrokes, which are X descent and Y descent. Any kind of an upstroke, that is A, C and V, is because of an increase in the right atrial pressure, which is reflected in the JVP. Why would there be an increase in the right atrium? There are 3 different causes for A, C and V. A is when there is an atrial contraction, which actually increases the pressure in the right atrium directly. That is A wave, A upstroke. Now C upstroke is because the atria have emptied the blood out here and the tricuspid valve is closed, and the ventricles, after contracting, are making this closed tricuspid bulge upwards against the atrium. So this kind of increases a little bit of pressure inside the right atrium because of the bulging of the tricuspid valve upward into the atrium. So this pushes it upward into the atrium. So there is a slight increase in the right atrial pressure. That is the C wave. After that, there are a few more events we'll see about the descent. When does the X descent happen? X descent happens when, if there is a descent, there has to be a decrease in right atrial pressure. So that happens when the right atrium relaxes. It has contracted, it has emptied out the blood into the right ventricle. Now the ventricles have started, contracting. Ventricular systole has begun. And during this time, first the right atrium, both the atria actually will relax first. And when they relax, they are ready to receive blood from the IVC and SVC. So IVC and SVC empty out into the right atrium now. And this filling is going to cause a V wave, a V upstroke in the right atrium, because anything coming inside is going to increase the pressure inside the right atrium. So that is, the filling during the ventricular systole is going to cause a V upstroke. And now, because obviously the right atrium and both the atria actually are full of blood, they are obviously have to empty that out. So when that emptying happens, that is when you have your Y descent, a decrease in pressure because of the emptying of blood out from the right atrium. Now, in what cases would you see a raised JVP generalized all over the waveform? Number 1, I already told you, when you have a right-sided heart failure or if you have fluid overload, overall your JVP is going to be elevated. Your entire JVP is going to be elevated. All the waves are going to be elevated. Now, generalized, if your JVP is elevated and if your pulsations are absent, that is in a case of SVC obstruction. Superior vena cava is obstructed, so pulsations are not there, but the JVP is elevated overall. Now coming to individual waves. So A wave, if A wave is isolated and it is, not isolated, if only the A wave is elevated a lot, if it is a large A wave, imagine a large A wave, that is because of tricuspid stenosis, pulmonary stenosis or pulmonary arterial hypertension. Why? Because in this case, there is a stenosis of this, so there is going to be an increased right atrial pressure to push the blood from the atria into the ventricle. So again, more pressure, so a large atrial contraction wala wave. Again, pulmonary artery stenosis, same reason. There is going to be increased right ventricular pressure, so therefore there is an increased right atrial pressure in an attempt to push more blood into the right ventricle. So again, atrial contraction is more, so a large E wave will be seen. And pulmonary arterial hypertension, again the same mechanism. Now A wave, there is another abnormality known as a Cannon A wave. Large A waves here, Cannon A wave is always seen when there is an AV dissociation, atrioventricular dissociation. That means the atria are beating at their own rhythm and the ventricles are beating at their own rhythm. This happens whenever there is a case of complete heart block, because there is an asynchrony in both the rhythms in that case. And that also happens in a junctional rhythm or any case of atrioventricular dissociation, basically. When that happens, the atria beat independently and ventricle beat independently. So imagine at some point the atria are now what if you have a giant V wave? V was for the filling of the atria during the ventricular systole. So the right atrium is filling here, but in case you have extra filling of the right ventricle than normal, Apart from the SVC and IVC, if it is also receiving blood from the right ventricle itself through tricuspid regurgitation, then that will give rise to a large V wave. So tricuspid regurgitation, TR, is an important cause of a raised V wave in JVP. Like we said, Y descent was because of the emptying out of the atria into the ventricles. If this is slow, that is if the Y descent is slow, that would be due to tricuspid stenosis, narrowing over here obviously, or it could be because of cardiac tamponade, fluid surrounding the heart. There is an important mnemonic here called PAY-TAX, wherein PAY means there is a prominent Y wave in case of pericarditis, constrictive pericarditis, and there is a prominent X descent when there is a cardiac tamponade. This is a basic overview. There are definitely more causes wherein we have abnormal JVP. If you want, we'll cover them in another video in more detail. But this was a basic overview and some important conditions that I mentioned.